Right. Hey, so I'm John White. Just to give you a slightly more specific title than Health and Human Services, which is broad. I'm at the Office of the National Coordinator for Health IT. We regulate electronic health records, or at least the electronic health records that are used by providers who provide Medicare and Medicaid services. So that's the context for me. I guess that makes me the Washington policymaker here. This is the reactor panel, right? So I had a reaction. And listened, was actually able to sit outside and listen to the talks. This is great because that meant I could yell at you on the screen while you were talking and you didn't hear me. So I heard a bunch of things I liked. I heard a couple of things I didn't like. So these are my quick reactions. So I like Craig Lipset saying he feels like he's living in a TED Talk, because I've had the privilege of working with some really talented people, several of whom are here in the audience, several of whom are back at the ranch working with me. And we've done things like Advanced Sync for Science and Sync for Genes, and taken that the infrastructure that's been put into place over the past 8 to 10 years in the healthcare delivery system, and turned that into a source of data, and not just a one-off. Okay, I've curated this very careful spaghetti kind of structure interface, but on a kind of deployed production basis. The direct volunteers for Sync for Science right now are able to, from certain EHRs, pull their data out and share that. So it's a shame that you all are still meeting tomorrow. Our ONC annual meeting is tomorrow and on Friday. If you were available, if you ended a little bit early, you could come over to the 2:45 session that we're having that talks about exactly this sort of stuff. So I would love it if you were able to come over to that. And if not, take a look at the live stream. So I was mildly concerned by the discussion about the usefulness of EHR data for research. And look, I get it. It's a cesspool. It's messy. It's nasty. It's missing whole Swiss cheese and da da da. But look, there's a couple of different arguments to counter that. Yes, it's difficult to work with EHR data, but it's difficult to work with researchers, and we haven't stopped working with them. So don't discard it just for that purpose. And the other perspective I give you is that it's data that you don't have right now, right? It's data that's out there that actually there are people here in the audience who have made that data sing and dance and do amazing things. And if you want just one thing to do to learn about that, go to PubMed. Search Denny GC or JC, Denny JC. That's Josh Denny, and take a look at his 275 articles that are on there. Pick a year, read through them, look at the references, and you'll have an amazing primer on both the challenges as well as the amazing things that you can do with the HR data. So I get it. It can be difficult to work with, but just think of the clinicians who first started thinking about the stethoscope and why on earth would I want a stethoscope, and try to listen. So it gives you a different window, right, on the world. It's a window that you didn't have before and you didn't know about. So I do think it's fairly useful. So the final piece I'll offer you was the idea of, and this gets back to what I actually do during the day, which is regulate health IT. So right now across the country, give or take 96% of hospitals that participate with CMS and about 80% of physician offices that participate with CMS for Medicare and Medicaid purposes have certified health IT in place, and they use it, and that's part of an incentive program, or was driven by an incentive program. So we were given a statutory imperative by Congress in the 21st Century Cures Act to make the data that are available in those deployed settings all across the country available to patients without special effort. And that's the actual phrase that's in the law, without special effort. Because right now it does require a certain degree of special effort to be able to get at your data, but you can get at it, which you couldn't do before. So we've got a rule that's sitting at OMB right now that's under review, a proposed rule, and you guys will be able to take a look at it when it comes out. But that's going to lay out our policy for how we're going to regulate those health information systems to make the data available through application programming interfaces to people without special effort. It's going to build on the API work that we've been doing, but it's an important piece of policy. It's going to be out for comment. I hope that you all will take a look at that. Not only is it meant to be able to make it available for purposes of treatment, but, and this is really the point that I want to get at with you all, is that it's Congress intended for us to make it available to patients, to people who are getting care. They need to have their data. They actually have a right to their data. It drives me bananas that they can't get their data. And this is the technological way that we're going to do it. We work very closely with our payer friends at CMS, as well as our scientific friends both at the NIH, at the FDA, because people need to get access to their data. And the point I want to make to you all is this. So we're going to work on freeing the data. I need you all to work on freeing your minds and embracing participants in these clinical trials, because we're going to give them their data, and then you need to go work with them to get their data. You'll be able to get it in other ways as well. But the right way, the virtuous way to do it is to embrace people and have them bring their data to you and do it to them with them on their terms. Stop treating them like fragile sheep, because you often do treat them like fragile sheep. They're not. Okay, and that's okay. You know, it's a change. You know, we all grow and change as time goes by, and you're really going to grow into a much deeper, richer, more rewarding relationship with your participants when you do that. So that was my reaction. Thanks.